Hey guys.
Well,
I finally got
getting
through
at
this.
this after
It's
all
where my
weekend
children
with my
never allow
children.
me to
Um,
get to my work, especially now that I have to help them with school. All right, so my slides are a little bit different than you guys. So you guys will hear me flipping through my papers and kind of because we've really cut out a lot of material. I know these slides really look like there's a lot of material on them, but I will help you through them. And if you guys have any questions, please get a hold of me. I really want
okay, I
to
don't know how
start
to
like
do
the
this. There we
Zoom meetings
go.
like next week probably. So that if you guys have questions, you can actually ask me directly. It's a lot easier to do that and a lot easier to understand when we can actually talk rather than me going back and forth with email because honestly, I really kind of hate email. I hate typing everything to people. I'm a people person. All right, so, where does this actually starts on page 4 of mine, but I want to kind of go over a few things um, that aren't on your slides. So my first slide is kind of basically it says, it's so much, how do I learn it all? Um, the things that I want you guys to know is the pathophysiology, the etiology, what causes it, the signs and symptoms, and any complications. That is what's going to make you a nurse. Being able to recognize it in your patient, say, that's what it is, these are their signs and symptoms, this is what could happen, and this is what I'm going to do to make sure that doesn't happen. So really, the biggest thing to realize, and I know you guys have been preached this, is the ABCs. ABCs. Without air, life's going to end quickly within minutes. If a person cannot breathe, they will die. If we don't do anything about it, they will die. Diagnostics. We need to know what's going to happen and um, what we can do about it because we're the ones that are going to see it and then have to call the docs. The docs are there. They see them, for a visit in the morning and then we're there with them the rest of the day. So we need to recognize what it is and what labs we're going to call and say, hey, she doesn't sound so good. I need a B&P and a chest x-ray. Just because that doc is only there for a few minutes in the morning. And then we have to know what's gonna make her feel better. So once we get the chest x-ray back, we're like, oh yeah, there's a lot of fluid in there. Call the doc, say, hey, can I give some Lasix? They will call us and say you should give Lasix, but it's actually makes our lives a lot easier when we can say, hey, can we have 40 milligrams of Lasix right now, please? So I just kind of want you guys to know, like I said, the pathophys slash etiology, signs and symptoms, and complications. And you know what? You're going to learn some in nursing school, but like I was talking to my brother yesterday, I learned 90% of what I know after I got out of nursing school. Um, this is textbook stuff. Once you get out in on the floor and seeing this stuff, you'll learn everything 100 times over. um, couple other things I wanted you guys to be aware of. Um, when doing a respiratory assessment, there's this mnemonic or whatever. It's called What's Up. WHATSUP. W is where is it? H, how does it feel? A, aggravating factors and alleviating factors. T is timing. When did it start? S is severity. You can say, give me a rating on a scale of 0 to 10 and how short a breath you feel. U is useful data. Maybe they're a smoker. Maybe they have a history of COPD. Maybe they have a history of asthma. Whatever will help. And then P is patient perception because they usually know their bodies. For you guys in my clinical group that saw and used that case study that I used with my daughter, she can tell you how to regulate her POTS more than any doctor can. It's kind of crazy. But what do you think is causing it? What does the patient think? Quick review. Crackles. When you hear crackles in the lungs, that means there's fluid in there. You need to figure out why. It might be because their IV fluids are too high and their heart isn't working as well as it should. So we need to figure out what it is, what's causing it, and get rid of it. Wheezes is when the airway is constricted. Think like asthma or pneumonia. Figure out why if you look at, say, the person's 12 years old, they don't have a temp, they don't have anything like that, but they do have a history of asthma and you hear wheezes, it's probably, the culprit is probably asthma, and you're probably going to want to give them a bronchodilator right away. Diminished lung sounds, usually you'll see this with smokers, people that have emphysema, maybe obesity. It's just a lot quieter than what it normally is. If there is no lung sounds on one side, that lung is collapsed and it is not filling up like it should. And then stridor is an obstruction of the airway. Whether it's croup, whether it's a bouncy ball, whether it's a penny, we need to really try and get that removed. Now, if they've swallowed something and there's no it's there, but it's not really obstructing the airway, they might just let it pass through on its own. But a lot of times we need to really make sure that we're catching everything we can and taking care of it. So those are my points that I wanted to show. You won't be tested on them, but I wanted you to know stuff like that. I will tell you, I will go over points that are very important for you to know, and I will give you kind of, hey, this is an FYI. Just because I think you guys need to have the whole picture, not just the test. All right. So, moving on. I do have this slide. Pediatrics. Some things, and I, like I said, I've got the same notes you guys probably do. But their airways grow until they're 12. So, things are pretty small. They get bigger and bigger, and they won't be adult sized till they're 12. These are all just FYI stuff on the notes. Upper airway, the size is very small. 4 millimeters, adults 20 millimeters. When we talk about alarms, I'll talk to you about my nephew Waylon. But just remember that the airway is 4 millimeters on a full-term infant. Yeah, you guys can look at the notes. Their airway resistance in infants is at increased for risk for obstruction, just because it's smaller. You can look at these. These are reading. Yeah. If you remember that the airway is like the size of a pinky finger, that'll help you remember that it's smaller. In the elderly, their respiratory muscles are not as strong as they used to be. All their muscles atrophy and they cannot cough, deep breathe, get rid of all the secretions and all the crud better than or as good as they used to. Their alveoli are not working as well. Their cilia is not working as well. And their macrophages are not opening as well. I have to pause this because my truck is leaving and my daughter is downstairs by herself. All right, I'm back. I just heard my truck start up and also wanted to make sure that wasn't my 8-year-old stealing my truck. All right. Elderly, they don't have the immune system that they once had. A lot of times their immune system is shot by the time they get that age. So a big thing we need to convince them is to get the pneumonia shot. It is a requirement in nursing homes. They're not allowed to be living in nursing homes if they don't have a pneumonia vaccine. So, I think that's about it that I want to go over on that slide. Information, but I don't want to overwhelm you guys. I want you guys to make sure you guys have the stuff you need. All right, so next slide. Diagnostic tests. Obviously, history, we're going to ask them history of asthma, history of smoking, history of ever having problems like this before, those types of things. We're going to do our own respiratory assessment. Blood work, chest x-ray. Sputum stains and cultures. ABGs, you guys have heard that. I don't want you guys to get all worked up about ABGs this semester. That is a CHA 1 or a CHA 2 thing. I will go over it. I will tell you what you need to know. And that's it. All right, pulse ox, PFTs, which are the pulmonary function tests, asthma tests, and COPD. So what do we need to know about the tests? We need to know what are the normals, what are the abnormals, what is the patient's baseline. For example, if you have a COPD patient, and I will punch this over and over and over, their oxygen sat and their CO2 level may actually be a lot lower, or their oxygen might be lower and their CO2 might be higher because of the way COPD works. And then what are nursing interventions before and after? Like, I'm going to listen to the lungs, I'm going to give a nebulizer, and then I'm going to listen to the lungs again. So those are the pieces that I want you to know about tests. You know, what do I do about it? Pulse ox, you guys have put pulse ox on over and over. It's the quickest way to determine if they're having trouble. If you put the pulse ox on and they're 78%, there's trouble. First thing to do is just get an ABG order. Sputum stains and cultures. If the doctor orders a sputum stain and culture, and I know we have to go over it in a little in the next few slides, just remember, always get the culture before you start the antibiotic. Otherwise, the culture will come back tainted. All right, this is a set of lungs. The ones on the left are healthy, happy lungs. It should be black. You should be able to see all of the ribs, and the one on the left is exactly what it should look like. The one on the right, that's fluid. That's fluid that you see in the lungs, which means pneumonia, pus, whatever does not look correct in the lungs. It's kind of like, it almost looks like a spider web or like cotton or something like that on the bad x-ray on the right. So just know you don't have to be perfect at reading x-rays as a nurse, but just be able to look at it and be like, oh yeah, that's kind of what it is. And it doesn't hurt. You can ask questions. I've asked a million questions on x-rays, MRIs, whatever. And the docs are always happy to give me the answer. So, all right, this is the slide with all the fun stuff on it. All right, where do I start? Red blood cells and hemoglobin. Red blood cells, that could be polycythemia. Polycythemia is what it is. The bone marrow is making too many red blood cells, so it could possibly mean chronic hypoxia or even a slow-growing blood cancer. When the person has chronic hypoxia, the kidneys are secreting more erythropoietin. I can't say the word, don't laugh at me. Which stimulates the bone marrow to make more red blood cells. So the hemoglobin and the hematocrit up, but they're immature. They're not ready to carry the amount of oxygen that it needs to. So the person actually has this ruddy skin color. I don't know if you guys have ever noticed it. Like if you see somebody with the barrel chest carrying the oxygen, they're usually like a gray color. So, if a person has a low hemoglobin, like say they're anemic, maybe they just had surgery and they lost a lot of blood, or maybe they are anemic, they might actually be short of breath because those red blood cells that are measured in the hemoglobin are not carrying the oxygen, and the person is like air hungry, trying to get the oxygen into their body. White blood cells, if we see a white blood cell count that is over 10,000, we can generally think there's an infection somewhere. And then based on the rest of their symptoms, we determine where that infection is. But if you see a white blood cell count over 10,000, there's an infection somewhere. Um, cultures. A sputum culture and sensitivity. For sputum culture and sensitivity, we are going to have them hock a loogie basically into a cup. It has to be, I don't know what the word I really want to use is, but a hangable. So you can flip it upside down and it hangs in the cup. I could never be a respiratory therapist, so uh, kudos to them. Um, what it does is it finds the pathogen. It tells me what pathogen is causing that infection, and it tells me the most effective antibiotic to treat it. So there's a million antibiotics out on the market. We kind of know which one goes for UTI, which one goes for a respiratory infection, which one goes for a skin infection. Um, but we never really know each person and how that specific bug will react to the antibiotic. We just hope it will work. So we do culture and sensitivities to determine what's going to work. We need to make sure, like I said just a minute ago, that we need to get the culture and sensitivity, the culture before we give the antibiotic. Otherwise, it'll pick the antibiotic up and it will be tainted. So to get this loogie in a cup, we have them cough and deep breathe, kind of get things moving around a little bit. We have a sterile container. Sometimes it's just the same thing as a UA container, the clear with the orange top. We're going to have them and spit into that cup. Sometimes we might need to use a neb to kind of get that stuff up. Because we want it from very down deep in their lungs. We don't want it from up in their nose or anything like that. We want it from the lungs. Yeah. So if any of you guys ever get on clinical with me, if we ever get to get back to clinical, that is the one thing I have a hard time is loogies. I had a patient hand it to me once, and I didn't know what it was, and I looked, and I about lost my cookies. All right. Oh, what else should we go over? Throat culture for like strep. It's basically to note the throat culture is to figure out what type of bugs are in the throat causing the sore throat. We never want to culture a kid that might have a laryngeal spasm. Like if they have croup, we do not want to, or even think that they may have croup, we do not want to culture their throat because that may cause a spasm in their in their throat. So we want to look for the red lesions on the back of their throat. Hold down their tongue, go in there, swirl around, pull it back out as quick as you can, and send it to lab right away. A lot of times after the throat culture, I give the kids a sucker. I always ask the parents first before I even do the culture if they can have a sucker when they're done, because it actually helps with the gag reflex. It works wonders. And never tell them, oh, it's not going to hurt. I don't ever like to tell a kid, hey, it's not going to hurt unless I know for sure that it's not going to hurt. But the same is true with throat cultures and like nasal swabs. We just never tell them it's not going to hurt because it may hurt and then they are going to not trust the system. Oxygen saturation. What all do I want you guys to know? It's just the percentage of hemoglobin that's saturated and carrying as much O2 as we want it to. You see it pulse oximetry, pulse ox, O2 sat, SaO2, and you even see it oxygen stat. That is not correct. It is not a stat. Stat means immediately. It is an oxygen sat, SAT, oxygen saturation. Basically, it's just a way to assess how their oxygenation status. It can be at rest, it can be walking, just whatever they're doing that we want to know that their oxygen is okay. Normal is anything over 95%. I think in the notes it says if it's 92% or below, we add oxygen, but I have always been taught 88, 89%, then we kind of look at oxygen. It really depends on, like if it's a COPD guy, We do not treat or throw on the oxygen real quick on COPD, guys. If the person is anemic or if they have fingernail polish on, that oxygen saturation is not going to be accurate. So we just need to take off the fingernail polish or use an ear probe. For a person to get oxygen at home, we want to make sure that they're going to get a overnight oximetry. They have to drop so low in order to qualify. It's really kind of a pain in the butt. You guys will see that because when people are starting to plan for discharge, they start testing and making sure that they are going to be able to qualify for their insurance to cover oxygen at home. And then if you are taking their oxygen saturation, please remember, if you remember nothing else from this class, if the rest of it all goes out the brain, I'm not talking this section, the respiratory section, I'm talking the entire class. This is one of the most important things I learned once I got on the floor. I had a doctor who I was deathly scared of. I had to call him and tell him the results of some test. I don't even remember what test it was. He asked me what the patient looked like, and I was like, well, the patient looks fine. And he goes, and it was in the middle of the night because I work nights. He goes, and then what the hell did you call me for? And hung up the phone. And so I called him back and I said, well, is there anything you'd like me to do? And he goes, yeah, I'd like you to treat the patient, not the machine. And hung up again. So yeah, I want you guys to remember, treat the patient, not the machine. I'll get into this when I actually have it in my lecture with my nephew in a case of where I treated the machine and not the patient. So when we see a patient has a low O2 sat, generally they're going to be restless, they're going to be confused, they're going to be agitated, and they're going to be anxious. All right. ABGs, doesn't this look scary? At least they look scary to me. Last time I taught this class, I had a respiratory therapist in class, and so I made her come up and teach it. All right. You can look at how to interpret ABGs. There's even this slide. But just kind of want you to get kind of an understanding. So, I'm just looking through all my notes here, sorry. pH, we want that between 7.35 and 7.45. That means the pH is okay. You guys have seen pH, like when you test your pools or whatever, your hot tubs. It's kind of the same thing. One way is acid and one way is alkaline. PaO2 is partial pressure of the oxygen. And PaCO2 is partial pressure of the carbon dioxide. So, if a person that has increased respirations, they're going to be in alkalosis because they're exhaling too much carbon dioxide too fast. That's why we have them blow into a paper bag, because then they're breathing their CO2 back in. Does that sound familiar with the new thing out about coronavirus, that if we keep our masks on all the time, we're going to be breathing all our CO2 back in? Decreased respirations is acidosis because there's too much CO2 building up. This is the most common. These people need oxygen. You're going to see, like I just said, level of consciousness is going to be decreased. They're going to be breathing about 10 times a minute. They might go into cardiopulmonary arrest. Might be because they've taken sedatives or narcotics. COPD would fit in here. Um, this is the most common. Anytime we do an ABG and we have like low respiratory rate, sedatives, anything like that, anytime we're looking at a respiratory failure, we're gonna order an ABG, and I bet you that ABG will come back with respiratory acidosis. That's what I want you to know from this side. See, respiratory acidosis. pH is low, PaCO2 is high, and HCO3 is normal. Um, what else? What else? HCO3, I forgot to tell you, is how well those kidneys are getting rid of bicarbonate. So, respiratory acidosis and alkalosis both are normal. But when it comes to metabolic acidosis, acidosis and alkalosis is when we look at the body getting rid of that bicarbonate. So, it's kind of a backwards and forwards thing. So some of this stuff I am really skipping because it's just going to confuse you. Early sign of respiratory failure, they're cyanotic, they're pale, decreased level of consciousness, confusion. Late signs of respiratory failure, though, is when the person actually looks like they're not struggling anymore. Because the respiratory system has just said, I've had enough, I'm done. And the person is probably on their way out. I think that's pretty much it with ABGs. They are drawn, if you've ever seen them drawn, they are drawn from the artery in the wrist, radial artery. It's enough to make grown men turn green. The first one I ever saw, I was a kid. My brother was a construction worker, and he had to have ABGs drawn for some weird reason. And I still remember it. He was a big tough guy. Okay, a little tough guy, but he was a tough guy. And he turned green and puked all over the floor, and then cried because it was terrible. So I have never had one drawn. It really kind of is scary to me to see one drawn and a patient not even flinch, because they're not doing well at all. But the needle goes at a 90-degree angle into the wrist. I love respiratory therapists. I cannot stress enough to thank your respiratory therapists. All right, bronchoscopy. This is a very invasive procedure. It can be used to do a biopsy. So if somebody's got, they might be having something on their CT, might be to go down and remove something in there, like a penny. My friend's daughter just ate a penny. That's why I keep referring to that. And they almost actually did bronchoscopy to get it, but she pooped it out after about 2 weeks, which was really kind of a scary are the bronchial tree. So when we have these, or when we're dealing with these, our most important thing is we need to assess their airway. We need to watch their airway. These people are kept NPO before the procedure and kept NPO until that gag reflex returns. They're given a numbing medicine for their throat, so that when the scope is going down, they don't cough as much. So they really have no gag reflex for this procedure. So they cannot eat, they cannot drink, they cannot do anything until that gag reflex returns, because otherwise they're just going to gag and cough and maybe give themselves pneumonia. So we just need to make sure we're watching their airway and waiting for that gag reflex to come back. Most important thing with a bronchoscopy. All right. So this should have a title on it called Nursing Interventions. We had to change all of our PowerPoints to be black and white, so some of this stuff came off without realizing it. So what are some of our interventions? We're going to monitor their respiratory status, their oxygen levels, their lung sounds, and just keep a good eye on them that way. Always provide any smoking cessation education. The more people hear it, the more likely they will quit. Kind of get them in the mindset and start planting the seed. There's so many things that come from smoking. Even later in life, even if after they've quit, it may come back and bite them in the butt. So the quicker they can quit smoking, the better. Deep breathing, coughing exercises. They can deep breathe and take and cough. They can do incentive spirometer. They can take a deep breath and blow out the candle or blow the Kleenex. Whatever they need to do to get those secretions moving in their lungs. Pursed lip breathing. You will see this with any COPDer. This is how they breathe. And if they are short of breath, you will really see them doing pursed lip breathing. It kind of helps them calm themselves, and it really kind of extends the expiration so they get rid of more CO2. Because the more CO2 they build up, the less drive they have to breathe, and their oxygen sat actually drops. Positioning, we always want them fowlers or semi-fowlers in the bed. We want them in a chair. We want them sitting maybe over the table in a tripod position, just so they're kind of up, and so their lungs are expanded and it's easier. If we get a patient up from the bed, they're sitting in their bed, they have to go to the bathroom, and then they're going to sit in their chair. Number one thing, if you take the oxygen off for them to go to the bathroom because it's too short, make sure you put the oxygen back on right away when you get back to the chair. There's many times that I have seen issues with this that, oh yeah, I forgot to put the oxygen back on. All right. Providing oxygen for our people here says 90. Anywhere between 88 to 90% is acceptable. Even in the small areas, like my little rural Viroqua hospital that I love dearly, we call the RTs. Hey, their oxygen stat's 82. Do you want to come help me out? Yeah, sure, I'll be right there. And they're there right away. So we might be able to put oxygen on them, but the RT is going to come and help us out. If the RT is not there, like during the night when Viroqua does not have RT, I mean, they are on call for big things, but not, hey, this person needs oxygen. We just call the doctor, get orders. MTI technique and education. These are very important. 9 times out of 10, you see a patient using their inhaler wrong. They don't know you need to wait in between. My dad used to fight with, I tell stories for everything. So, my dad used to fight with the RT because this is the way he did his inhaler. He would put it up to his mouth, click it twice, say, yep, I got 2 sprays. Fred would always yell at him every time he was in the hospital. And my dad would just get mad and tell Fred, this is the way I do it. But we always need to really try and teach them how to use their inhalers. So take a deep breath in, blow it out. When you breathe in, squeeze the inhaler. Then wait a minute in between. It'll really decrease some of the side effects with it. Nebulizers, you guys have done that. Not too much. It just gets the medication down in their lungs. Good. Anytime that we need to do a respiratory intervention, we need to make sure that it is the least invasive. Always make sure that the O2 is on, that the nasal cannula is in their nose. Make sure their head of their bed is up. Try and get them cough and deep breathe. Things like that. if they're if we have them on an oxygen saturation machine and it's beeping, don't ignore that. Make sure that the probe's on correctly. Look and see if they're having any problems whatsoever with respiratory distress. Their oxygen sat, maybe check it with another machine. But never, ever, ever, ever let that machine keep beeping, because you may be treating the machine and you need to be treating the patient. My nephews, for my guys that I had in clinical, you guys know my nephews. But my twin nephews were born mono twins, which means there was no sac to separate them, so which means they were high risk, and mom had lots of problems. So they're pretty special. They have really survived and done very well. We never thought they'd even make it here. So, and tomorrow they'll be 4.5 months old. So it's been a long year. But anyways, so they were in the hospital for about a month after they were born. They were born at 32 weeks. And Waylon came home on oxygen. She called me one morning and said, "Hey, do you want to come look at Waylon's oxygen machine? It keeps alarming, and I don't think it's reading right." Okay. So I said, "Well, do you need me to come right now, or can I go do a few things?" "Oh, you can go do a few things, not a big deal." So I went over to my mom's, and she had to buy a new car, and my brother decided to take over and do it. And I was like, "Oh, great. I'll just go over and check on Waylon." Otherwise, I wouldn't have been there till 5 o'clock at night. I went over about noon. Walked in the door, and it started beeping right away. I looked, his heart rate said 62. He was pink and moving around. I was like, "Yeah, his heart rate ain't 62. So I sat and I listened to him. I'm like, his lungs, they're kind of questionable, but I'll just keep an eye on him. But I want to check the machine. So I looked at it. I made sure the probe was on right, blah, blah, blah. So I called the company. I said, "We need a new oxygen machine." And this was on a Sunday, so it was kind of a rigmarole. And I had that all set up. They were going to deliver it. Everything was ready just to swap out the machine. And I looked at her and I said, "I just don't feel right." I said, "I think I want to sit down for a little bit with Waylon and just listen to him." And I said, "So when I'm holding him, just kind of let me be in my own little sense of myself." And I listened to him for probably a good 10 minutes straight. And every time that alarm went off, yes, his heart was dropping. It would slow way down. And every time his oxygen sat would drop, he was stopping breathing. I have never been so, I don't want to use the word calm, but I was calm and looked at her and I said, "Morgan, Cody, pack your bags, get the hell out of here and get this kid to the ER. You get out of here. I'll call the ER on your way and let them know you're coming, so they will meet you at the door. Actually, I want you to drive right into the ambulance bay." And they did. They got there. They did the x-ray, found pneumonia. Okay, great. Life is good. An hour after they were there, Waylon's heart rate dropped down to, I don't know, 30s, 20s. And they were performing CPR and giving epi, and now he's kind of their trophy baby because they never thought he'd make it. He was med flighted out. Two days later on Tuesday, I med flighted his brother out because I wouldn't allow her to take him because it was flu season. So, yeah. So always, always, always treat the patient, not the machine. And always make sure your machine is right. So that's my big thing of never, never just treat one. Never, never just treat the machine. All right. Off on my soapbox. This lecture is going to be hours long. All right. Incentive spirometry. We call it the IS. It's on everybody's table that's had surgery or any problems breathing. You guys have seen it. You see, a lot of times you'd think it was that would be they were blowing, but it actually is they have to suck, and that's what's measured. Not they're blowing, but when they suck in. It's going to make people cough. and that's what we want it to do. It just prevents pneumonia, and like I said, it really is not a measure of how much they're blowing out. Bless me. It is a measure of how much they're, what's kind of a measure of how much they're breathing in. We have a goal set, maybe 1,500 or 2,000, but it doesn't really mean, doesn't, we just set their goal based on what their baseline or what they can get at. RT is one that sets the goal. We want them to do it as frequently as possible, but general orders are 10 times an hour while awake. So every hour they're awake, we want them to do it 10 times. We actually walk in and say, hey, did you do your breathing thing lately? Yes. No. What do I want you to know off here? Chest physiotherapy, RT will do it. It's just they're trying to get the chest cleaned out by doing percussion and vibration. You might see a chest physiotherapy vest, most commonly done with cystic fibrosis. But RT usually does this. Thoracentesis, we are going to see once in a while. This is just the insertion of a needle, a big needle, into the pleural space. Fluid's going to come out from pleural effusion, which is just fluid trapped in a pleural space. Can be done for a diagnosis, or can also be done to help them breathe better. They're going to sit and bend over the bedside table, kind of like in the tripod position, so that the provider can get to the right place. If they are absolutely unable to sit, then we're going to lay them on their side. But biggest thing is have them sit at the edge of the bed with their arms over the table, so that they're sitting up so the provider can get to where he needs to. We're going to be sitting in front of the patient, just so that we can assist and keep them calm, keep them breathing, keep them still, so that they have somebody there in their corner. I've seen it remove big, huge amounts, like 2 liters. You can take a whole lot out, and the patient generally feels much, much better. And then we're going to put Vaseline gauze over the needle site so the air doesn't get into there. All right, I'm trying to move quick on some of these that we don't need. I'm going to skip this, not this slide, but the one slide that I have. Okay. Rhinitis or coryza you might see. It just means a common cold. It's viral. Might be allergies. Slow onset. You guys know this stuff. And the mucous membranes are inflamed. Histamine and vasodilation. Edema around the eyes, nose, throat, sore throat. Sometimes there's a fever, sometimes there's not. Feel under the weather, runny nose, sore throat. Not a big deal. I'm going to increase my fluids, and I'm going to use Vicks. Influenza is a little bit more different. You guys are very familiar with this if you guys work in any hospital. It's also viral, droplet transmission, or even physical contact. It's a sudden onset. It comes on overnight. It's got a very high fever, muscle pain, like fatigue, malaise, headaches, coughs, and actually like a systemic, all body systems are involved. Sometimes it can develop into pneumonia. And I can't stress this enough. Teach our patients to get those immunizations. Yes, I know the influenza shot only covers certain strains, but if you get the strain that you are vaccinated against, it will be a lot less worse. Once you have gone through there's one year I didn't get a flu shot, and that's the year I got influenza. It was terrible. Antivirals, Tamiflu is given, but I've really kind of noticed that they're backing off on that a little bit. Pharyngitis is just a sore throat, inflammation of the pharynx. Viral bacteria, most common strep throat. They're going to have trouble swallowing. Their throat's going to be swollen. In strep throat, you're going to see white patches on the back of their throat. They're going to be very red. Rapid strep test is done, and that comes back pretty quickly. I think within the hour. Penicillin or erythromycin. Basically, you're going to treat that viral infection symptomatically. If they do have strep and they leave it untreated, it could go into rheumatic fever. So just make sure that we're always looking for strep. I have to pause this because I'm getting emails left and right, and I apologize for the hold up, but I want to make sure I am not missing something from you guys. Alright, I'm back. Oh, hold on. Alright, laryngitis. That's inflammation of the voice box. Might be bacterial, might be viral, might be alcohol related, might be smoking or breathing in chemicals, or might just follow an upper respiratory infection. You're going to see hoarseness, cough, dysphagia. If it's bacterial, we're going to give antibiotics. We're going to tell them to not be talking, so we're going to give their voice a rest. Increase fluids, try and get humidified air, Tylenol. If the hoarseness lasts more than 2 weeks, tell your patient to see their provider to rule out cancer. My grandfather had laryngeal cancer, and he had like a raspy voice for as long as I can remember. So I have no idea how long it was brewing, but they kept telling him, "Yep, you got laryngitis. You got laryngitis." And when it finally wouldn't get better after a very long time, they went in and found that it was cancer. So make sure we're teaching them that, like, if their hoarseness is longer, like even like 2 weeks in one day, just to make sure that we're not missing something. I'm always scared of missing something if you can't tell. All right. COPD. COPD is been changed, kind of. No, maybe a little. Is 3 disease processes in one, because it's chronic obstructive pulmonary disease, and it just includes chronic bronchitis, emphysema, and asthma. Chronic bronchitis, because there's always getting in bronchitis. Emphysema is generally caused by smoking. And asthma. It doesn't help. Oh, Pam changed this on me. I have always been taught, and apparently they just changed it. Okay, fine. Bronchitis and emphysema are parts of COPD. Asthma is no longer considered part of COPD. It's a respiratory disease, a constrictive respiratory disease, but not under COPD anymore, because it comes and goes with exacerbations, where COPD is chronic, it's progressive. So COPD has, like I said, exacerbations. Sometimes they're doing okay, sometimes they are doing terrible. After a person has an exacerbation, they don't come back. They don't return to 100% baseline. It's not like a sickness where you get sick and then you feel 100% better after a while. Their airway, their lungs don't get back to normal after they had this exacerbation. COPD is a huge risk factor for lung cancer. A person who has COPD, I mean, plus they smoked, but it destroys the cells, and then their cells procreate this messed up formula, and the cells are not right, and then it turns into cancer. So it's caused by all the inflammation from COPD. What else? Um, Clubbed fingers. I don't know if you guys have had the ability to see that yet. But COPDers, because they're low oxygen levels, the chronic low oxygen levels, their fingertips actually become kind of clubbed and rounded. You should look up clubbed fingers. You'll see it. It's strange. COPD can be prevented, but once you have COPD, it cannot be cured. The symptoms can only be treated. Um, I spent a lot of time learning about COPD and lung cancer because I lost my dad. Is it 4 years now? To lung cancer, and I actually did that. Yeah, it's 4 years now. I actually did my master thesis project on lung cancer. So whatever you can do to prevent COPD, because it's very hard to treat the symptoms. I used to call my dad my train. I could hear him walking in the house before I seen him from 3 rooms away. So COPD, try and teach these people to be preventative. This is just a view of the air sacs. This is what it looks like with COPD because there's so much mucus they can't get it out. You can see how they're nice and pink and bubbly and, uniform kind of. With the emphysema, no, they're just full of gunk and very small room for air in there. The dark spots where the air goes. So, oh, we lost the picture. Anyways, treatment focus is for relieving symptoms. If we can teach them to stop smoking, if they're diagnosed with COPD, we really need to try and convince them to stop smoking. My dad was diagnosed with COPD long before he quit smoking. He had a stroke when I was 5. And they told him if he didn't quit smoking, he'd never see me grow up. So, it wasn't that he was diagnosed with COPD, it was that he had another health illness. We need to make sure that we're trying to teach them to stay in clean air. Don't be standing over grills or people with heavy perfume or scented candles are a terrible trigger. If we can open windows and have fans blowing, and make sure we're giving them anti-anxiety meds because anytime you're short of breath, it really throws your anxiety for a loop. We need to teach them to take meds as prescribed and avoiding triggers. Like I said, don't have them standing over the grill. We can maybe slow it down, but we can never cure COPD. So the biggest thing is having them quit smoking. COPD and oxygen. I'm reading what this thing says. Okay, so if we have a patient who has COPD and they're short of breath and their oxygen level is below their baseline, so maybe their baseline is 88 and they are sitting at 82. Somebody that does not have COPD, you're going to throw as much oxygen on that person as you possibly can to make sure that their levels are are much, much higher. With a COPD patient, we don't want to give them over 2 liters. If we give them too much, it's actually going to drop their oxygen level. I had a lady in the nursing home on another wing, new travel nurse, did not know that this person had COPD. She complained of being short of breath, so she threw on 4 liters of oxygen on this lady. And then called me. Well, she's like, well, she's doing okay. I said, okay, I'll be down in 5 minutes. By the time I had gotten down there, her oxygen saturation had gone from 82 to 74. Okay, what happens when somebody's at 74? They are nervous, they are anxious, they are tearing themselves apart, they are just air hunger. I mean, it was terrible. And I said, how high do you have her oxygen on? Well, I got it on 4 because she was, whatever it was, 82. And I said, oh, no, put it on 2. And slowly but surely, this poor lady, her oxygen level actually went up when we decreased the oxygen. she got more pink. I mean, when I got down there, she was literally gray. Um, and she was pursed lip breathing through the whole time because she was with it enough that she could follow directions. Um, but it was really like evident that, hey, whoa, don't ever put more than 2 liters on a COPD patient because it could be very bad. Because it just their dioxide levels, their CO2 levels build up in the blood, and then they have no drive to breathe, so it slows their breathing down, and their breathing gets shallow, so they're not breathing in the oxygen or blowing out the carbon dioxide. They have a trouble getting the carbon dioxide out anyway with COPD, but when we eliminate their drive to breathe, I can't talk, I'm sorry, that carbon dioxide builds up much more. Normal oxygen, like I've been talking, normal O2 sat for COPDers, 87 to 89 is what the notes say. So about that. All right. I'm trying to move on faster with some of these things. Some of these things I like talking about. I'm a respiratory dork. All right. So what else can we do for our people? I cannot stress educating them, and I cannot stress the pursed lip breathing for the COPDers, or even anytime somebody's in respiratory distress, because it actually, like I said, their exhalation time gets longer, and it takes away that CO2, which blocks out their drive to breathe. So, pursed lip breathing, COPDers, respiratory distress. We can teach them meditation, relaxation, diversion, but a lot of times they are going to be on an anti-anxiety med. Aromatherapy. Be very careful. Be very careful with these. The odor can actually exacerbate symptoms and make them worse. I've seen people think, oh yeah, this is a great thing to do for grandma. Comes in, their room smells like, 17 different oils. And grandma's like, I can't breathe. So we literally had to take her out so we can air out her room. I mean, then the granddaughter was just trying to help, but some of those odors are just too much for them. Another big thing, remembering these people that have low O2 levels or lower than their norm, their early symptoms, they're going to be restless, they're going to be confused, and they're going to be agitated. So, moving on. Oh, maybe not. We're still on COPD. This might help you, though, when you guys got to do your NPWs. These are just some nandas for COPD. Biggest one, ineffective airway clearance, impaired gas exchange. We can do imbalanced nutrition, less than required, less than requirements, because they're worn out from trying to breathe. They don't eat as well. Maybe compromised family coping. Maybe family's upset that the person has COPD, and maybe the person might be end-stage COPD. And decisional conflict. Maybe they know they need to quit smoking, but it's an addiction, and it's hard to get rid of an addiction. So those are just some nandos for you. Where am I? You guys can look at this. We went over bronchitis, I think. Acute is just usually after an upper respiratory infection, it moves a little bit and you get bronchitis. Chronic, it happens because the person is a smoker. It's related to COPD. If it's a bacterial infection, we're going to treat with antibiotics. We're going to get them to cough and move that fluid during the day, and then we're going to suppress their cough at night. And educate on non-smoking. You can just take a look at this slide when you go through it. Chronic bronchitis, like I said, this is part of COPD. There's a lot of mucus secretion in the bronchioles. You're going to be seeing like a productive cough. They're going to be coughing stuff up, lasting 3 or more months of the year in 2 years. So it takes quite a long time to be diagnosed with chronic bronchitis. What's the next one? Oh, I don't have this slide. Haha. Well, maybe I do. The name on this slide should be bronchiectasis, which is just basically that the bronchial airways get dilated and they're flabby and scarred and there's sacs, like diverticulitis, but in the airways, and the secretions sit in them, and it can actually get moved to an infection. Difference between bronchiectasis and bronchitis. Bronchiectasis has an excessive amount of purulent sputum. Their biggest thing is just try and keep their airways, watch their airways, keep them clear. Emphysema. Another word for these is pink puffers. Just because the inner wall of the alveoli weaken and rupture. There's large air spaces and the surface area for blood exchange or gas exchange is reduced. So the oxygen is reduced and it moves into the bloodstream and they become almost red. Caused by smoking. Their chest elastic recoil is lost, so they become a barrel chest. Emphysema starts gradually over years. Air's trapped in, like I've been talking about the barrel chest. Air's trapped in the lungs and in the wrong place, so it pushes that chest wall out, and then there's less alveoli and less actual airflow going through them. Their chest recoil is diminished, so that chest just forms over those enlarged lungs. Now, there's so much because of the bronchitis. There's so much gunk in their lungs that they cannot expel all of the CO2. So that also causes their lungs to stay open and causes that chest to become barrel chested. Remember I said on the first slide when there was a few things I wanted to get through that the lung sounds were diminished? This is also where it says, see, they're diminished because the person is a smoker. No, I'm not getting down on smokers. I'm just trying to make sure the point gets across. I grew up in a smoking family, and I'm not against it. I have no qualms either way. All right, common meds we're gonna give for these guys: emphysema, bronchitis, COPD, is adrenergic bronchodilators, like an albuterol. We want those bronchioles to open up. Can be in an inhaler, can be in a nebulizer. But we may see their heart rate jump up, or they might see them tremor. We always want to give these first because they will open everything up, and then we can get the medicine down. If we give the other ones first, then we're setting the medicine into constricted airways. So after they're open, we're going to give them like an anticholinergic agent, like Atrovent or Spiriva. In Spiriva, it's actually a capsule that goes into a special inhaler, and the inhaler pokes a hole in it when you press the button, and then they breathe in the powder, and it gets down in their lungs. It's kind of cool. That does like a long-acting bronchodilation, whereas the albuterol does a fast-acting. There's a Spiriva inhaler. Those are the pills. It's really kind of cool. And there's an albuterol inhaler. All right. Oh, where are we? Oh, nebulizers are usually given to open the airways. Generally, people think they can only be given every 4 hours, but they can actually be given back to back sometimes. I've seen extremely short of breath patients just get them back to back till they can breathe. Going to give them corticosteroids to decrease the inflammation. Prednisone and Solu-Medrol are the most common. IV obviously works faster. If they're in the hospital, they will get IV probably 2-3 times a day. just so that inflammation can get down. Typical COPD patient has lots of meds. An anticholinergic that dries the person out because there's all that mucus in there. It's going to dry them out. How you remember anticholinergics, that it dries. The way I remember it is anticholinergics can't see, can't spit, can't pee, can't shit. I don't know if you guys were taught that in pharm, and I don't know if I'm supposed to say that, but it's the best way to remember it. Anticholinergics are something like atropine or cogentin. Anti-anxiety meds they'll be on, generally a benzo. Just remember that anytime somebody's short of breath, they're going to be anxious. Nebulizers like the albuterol and the duoneb. Rescue inhaler. And they're going to get the corticosteroids for flare-ups. At home, they might be given prednisone. In the hospital, it'll probably be IV Solumedrol. So it just kind of depends on the patients. But we also do have to remember that side effects of these steroids, the corticosteroids, their immune responses tanked. So puts them at risk for lots of other things. All right, moving on to asthma. Chronic inflammatory disorder, obstructive disorder. It recurs. It depends on, it has different episodes. What we're going to see is wheezing, breathlessness, chest tightness, and coughing. They're higher risk for pneumonia because anytime they have a flare-up or anytime there's something that happens to the lungs, they're not as healthy anymore. They can't just bounce back to 100%. So they're at higher risk for pneumonia. So these are the patients that we really need to teach to take that pneumonia vaccine too. And their yearly flu shots because we don't want pneumonia or the flu shot to happen because it would be much worse for them. All right. So what happens with asthma? You're going to see a trigger. They might be around cigarette smoke. They might be around perfume. They might be around something that is their trigger. They're going to have bronchoconstriction. So everything's going to constrict and their mucous membranes are going to become inflamed and there's going to be edema. So, you got the outside constricting in, the inside swelling up. So their airway, they can't move their airway. And then we're going to have extra mucus production. So the whole thing is just not a good situation. Their airway is going to be narrow and they're going to be wheezing and having a really hard time breathing. So you'll see an increased airway resistance, limited airflow. You're not going to hear them moving a whole lot of air back and forth. And they're really going to be struggling, working hard to breathe. Some of the asthma risk factors, allergies, genetic factors, environmental, they're precipitating factors. The list is, I don't know if you guys have the notes. You guys should have notes. If you guys don't have the notes, let me know. I will get them to you. Smoke, dust mites, pollution. Sometimes cockroaches can cause asthma flare-ups. Pets do a lot. Mold does a lot. Anytime somebody's around smoke, like campfire, garbage fire, somebody smoking, perfumes are too much, especially if they have an upper respiratory infection, they might have problems with their asthma flaring. The weather might be enough, and like allergies. So this is what you'll see. I think I've gone over this a million times. Chest tightness, dyspnea, wheezing, cough, tachypnea, tachycardia, anxiety, and apprehension. All right. So some of our complications of asthma, we're going to see pneumonias, we're going to see atelectasis, we're going to see pneumothorax, we may see cor pulmonale. That's severe, severe, severe. Status asthmaticus is just a very severe, very prolonged asthma attack that does not respond to treatment. It's very serious. Um, so, what are symptoms of impending respiratory failure? Restlessness, tachypnea, anxiety. I can't stress that enough. Decreased level of consciousness or confusion. Can't stress that one either. Um, they may be cyanotic. They may be grunting. You will see retractions. Um, so, um, yeah. So what do? Stay calm. A big thing with me is that if we as the nurse are anxious and oh my gosh, oh my gosh, oh my gosh, that's going to transfer to the patient. It's going to make them 100 times worse. So even though if we're freaking out, we need to keep that on the inside so that we're nice and calm on the outside. We're going to remove the trigger if we haven't done so already. We may be giving EpiPens or epinephrine to get their breathing back. And we're going to make sure we're giving meds to open up those airways. So, I will not lie, I have a whole mess these next few slides. I have a lot of notes and a lot of things crossed off, so I'm just going to go through the important stuff. So, meds for asthma. The first med to be given with an asthma attack is a bronchodilator. This is your albuterol. Sometimes you'll see it mixed with ipratropium, called a duoneb, or you might see levobuterol. But the first med to be given for an asthma attack is a bronchodilator. Those airways are going to open up and it's going to make breathing a lot easier. Another med that we're going to give is steroids. It's going to reduce all that inflammation that we talked about in an asthma attack. So it could be prednisone, it could be Solumedrol. But in an acute asthma attack, it's going to be an IV Solumedrol. Methylprednisone is a pill too. Steroids have a lot of side effects. It really drops out a person's immune system. So if somebody's on prednisone, they most likely don't have anything to fight off an infection. Actually, they've been trying not to use steroids as much as possible lately because of all the COVID going around. The people have problems, obviously, fighting off COVID if they are on steroids because they don't have anything to fight it off with. Biologics are also ones that will knock out the immune system. Leukotriene modifiers, that's like your Singulair. Go back. Oops. For like, you'll see patients on, what they call maintenance meds, and these are going to be, like inhaled corticosteroids. It's daily. It's to prevent the asthma symptoms, and these are the meds like Flovent or Pulmicort. I think you guys have probably seen the inhalers. They're round and purple, or like blue, I think. But they're different inhalers. They don't look like the albuterol inhalers. You have to slide them open and then pull the clip back, and then they breathe in the medicine. But daily, they're going to be taking inhaled corticosteroids for asthma symptoms, like Flovent and Pulmicort. All right. Gotta go through 18 pages here. There you go. Nursing diagnosis for asthma. You can keep this and use it for your NPWs. I'm not too worried. Ineffective airway clearance, ineffective breathing pattern, anxiety. What is the primary focus for your patient? I feel like we've gone over this. We have gone over this. You it. What type of breathing are we gonna do? Ah, pursed lip breathing. All right. Moving on to pneumonia. Hold on, I'm gonna just check my email on my phone real quick, make sure nobody needs anything. It's the first day of class, so I'm a little nervous about missing an email from you guys. So nope, I'm good. All right. Pneumonia can be mild. It can be life-threatening. You're gonna see it most serious for infants and young children, people older than 65, and again, people with weakened immune systems, or other health problems. Um, yeah, my nephews had HIV, which is pretty much eradicated because of vaccines, but they were 6 days away from their vaccine. No idea where they got it. But their pneumonia was so terrible that Waylon was intubated, and when they tried to pull it out on Wednesday, he did okay for about half hour, and then they decided that they had to put it back in because he started tanking. But his pneumonia and the swelling from the hip and his throat, they couldn't actually. They had a really hard time getting him intubated again. So um, just know that infants, young children, and older people and people with no immune systems are more at risk for pneumonia. Um, the air sacs are filled with infection. Um, Pneumonia can be infectious or non-infectious, contagious or not contagious. Some types are community acquired, getting it out in the community. They might get it from the hospital, or it's either nosocomial or healthcare acquired. Um, they might get in the nursing home. There's aspiration pneumonia, um, pneumocystitis, carinium pneumonia. I'm not even sure where that comes from. That's one of Pam's notes. I don't have a book to teach you guys, so I'm using Pam's slides because Pam's amazing. But anyways, it can be bacterial, it can be viral, it can be fungal, um, and it could be aspiration. So there's a lot of different types of pneumonia. You think there's only one, but there's lots of different types. Pneumonia is always diagnosed with a chest x-ray. I went over that chest x-ray at the beginning. Use that and remember that it's always diagnosed with a chest x-ray. um, this is just the pathophys of pneumonia. Microorganisms, or maybe like food or water in aspiration pneumonia, get through the respiratory tract and settle in the alveoli of the lungs, triggers that inflammatory and immune response, and then those alveoli fill with crud because um, that the food or the bugs have already settled in the alveoli. So the alveoli, the inflammation is causing all the fluid to build up. Um, and then we already went over the bacteria, fungi, virus. Pneumonia can actually enter the through the bloodstream. It's kind of scary. Let's see. Signs and symptoms. Sorry, I had to skip a slide here. Um, it depends. It kind of depends on the person. If they're unhealthy or they have a poor immune system, if they're young, if they're old. You might see shaking, chills, fever. They might be sweating. A lot of times you're going to see them coughing stuff up. Might be rust colored, must be purulent. That's one thing I always watch in the kids if they have a really bad cold. What are you coughing up today? What color is it? So now my kids have turned into saying, "Yep, Mom, I'm coughing up, but it's clear. It's okay. We're good." In pneumonia, you're going to see chest pain or pleurisy pain, pleuritic pain. They're going to be fatigued. Um, they are having crackles. Hold on. Um, And you might also see nausea and vomiting and diarrhea. They'll be short of breath. Here's a little picture to remember. In the older adults, we're going to see them, they might have very minimal coughing. They might not be spitting up a whole lot. They might not even have respiratory distress. And sometimes their temp's going to decrease rather than increase. But what you may see, their breathing may get faster. And but generally the first sign of older adult elderly pneumonia, their first sign is their agitation or their mentation is different. So remember that. Complications. I gotta find my slide. My notes. Okay, we don't have it. I'm going. Usually in a healthy person, pneumonia will resolve without issues and no damage to the lung tissue. However, if this person has COPD or other issues, it can cause scar tissue buildup, which leads to poor breathing, everything. People might actually get bacteremia and go septic. Pneumonia, they may have much more problems breathing because there's a lot more fluid than there normally is. You might see lung abscesses, pleural effusions. Yeah. Just note the biggest thing here is that it can actually enter the bloodstream and they can actually go septic with pneumonia. Treatment. I have my notes. Prevention. Vaccination. Don't smoke. Keep your immune system strong and going. Medications that you're going to see for pneumonia, obviously antibiotics, bronchodilators. They're going to be given Mucinex to try to dry all that crud out. They could be on oxygen, and they're going to be on fluids to make sure they're not getting dehydrated. All right, moving on to tuberculosis. TB actually kills 2 to 3 million people a year. Not in the U.S., I mean, not in our area, but in other areas, it's actually, it actually happens. It's not common around here, but if these people come in, they're going to be in a negative pressure room because it is a droplet. You know what I'm saying? Transferred by droplets. So if it gets in the ventilation system, it can be transferred to everybody in the hospital. Sometimes, I mean, it can be latent TB and it can be active TB. Latent TB, there's a TB infection, but the bacteria in the body, it just is not doing anything. It's inactive. You can't pass it on. But the problem is this actually might become active. Active TB, you're sick and you can spread it to others. It'll happen within the first few weeks of getting exposed, but it may even take a while, up to a few years. Oh, look, just told you that. It was in my notes. We are actually getting down there. In the U.S., 10 million people actually harbor TB, the inactive, latent. If their immune system gets compromised, it'll become active. Risk factors for TB is crowded, poorly ventilated areas, and the elderly. Sometimes when people are immunocompromised or AIDS, obviously that's more the bigger risk factors. Diagnostic tests, you guys have all had PPDs done. If there's any induration, there's any like swelling and it's hard, then it becomes positive. And then generally a chest x-ray is done to rule it out. If there is questions on the chest x-ray, there's going to be a lot more testing done. Um, Interventions, these people are going to be on isolation, like I said, in negative pressure rooms. They're going to be wearing filtration masks. Um, all um, infection control department's going to know definitely about a person with TB. And if they leave the room, they have got to wear a mask. They cannot go out without a mask. TB symptoms, they're saying that coughing that lasts 3 weeks or longer. More common, the more telltale signs of TB, they're going to be coughing up blood, chest pain. They're going to lose weight, and they're not going to be trying to. They're not going to be dieting. They're going to be tired. They're going to have fever, chills, and night sweats. A way to remember the TB symptoms, if you guys have ever seen, oh my gosh, what is that name? Tombstone, the movie Tombstone. My God, the names are totally lost in my brain right now. One of the guys on there, the guy that says, "I'll be your Huckleberry," that's the only way I can remember him, actually has TB in the movie. And it's totally textbook symptoms of TB. He's drenching wet with sweat. He's coughing up blood. He's just completely worn out, and he's one of the gunfighters. But he looks textbook symptoms. So if you guys need help remembering TB symptoms, watch Tombstone, and you guys will see exactly what I'm talking about. All right. There's different types of meds that people with TB have to take, because they might have antibiotic resistance. And the treatment takes a very long time. Just because there's side effects, it's just a very long procedure to rid the body of TB. Generally, they're going to be 2 to 3 antibiotics. They have to have their liver watched because they're toxic to the liver. Yeah. Let me see if there's any more. Yep, there we go. Rifampin. People with TB that are taking rifampin will actually complain that their urine is orange, because it just causes their urine to become orange. They might be on isoniazid. Yeah. All right. Moving on to something a little more common, influenza. Actually had a discussion with my family about influenza and the flu yesterday. Yeah, one of my family members was trying to be a smarty and out-talk me, and my oldest daughter says, "Okay, let's argue with the person with the master's in nursing 3 semesters away from having her doctorate in nursing. Just shut up." That was kind of funny. Anyways, it is called the flu, but it is not the flu. Influenza is the respiratory illness, and the flu is generally considered the GI. That's where everybody gets kind of confused. Influenza is very highly contagious. It's a virus, and there's many different strains. And generally, we can only vaccinate against like 3-4 strains because we're just predicting of what strain's coming based on what strain was here last year. We have a flu, I don't know if we want to say epidemic based on what we're going through now, but yeah, we have big, huge breakouts every 2 to 3 years. If you've ever worked in a nursing home and had to shut down wings because of influenza, that is the most terrible thing ever. These poor elderly adults are just not understanding why they can't see their friends, they can't see their family. They're going through it 100 times over right now, but in influenza, before coronavirus, influenza shutdown was the worst. Influenza can actually lead to pneumonia. Symptoms that we're going to see: coryza, which is the runny nose, fever, cough, headache, and malaise. You just feel terrible. in malaise, I want to include body aches because you just hurt everywhere. Everywhere. All right. So the virus comes in and it affects those epithelial cells in the respiratory tract. Those cells will replicate quickly, spread to other cells, and become inflamed. Anything that's inflamed can actually happen to die. And the cells will be shedded out of the respiratory tract through like runny nose or sneezing or coughing or something. So you're spreading the influenza. You're basically dead cells are coming out your nose when you sneeze, and you're giving it to the next person. It just takes a long time for the fresh, new, healthy cells to replicate. Influenza type A is what we see. Type B is maybe what we see after a person has type A. It's less severe, and sometimes people don't even know they have it. Type C is very, very mild, and it really not too many times type C actually will go unrecognized. I honestly think Pam is including coronaviruses in the influenza types. It's basically kind of the same thing because it does attack the respiratory system. I honestly have not done a whole lot of research on the coronavirus myself. Yeah. All right. We wanted to include this. So you guys have probably heard all this already, but CO for, in COVID, CO is for corona, VI is for virus, and D is for disease. Different types sometimes just cause mild upper respiratory tract infections. But COVID-19 is a new type of COVID or coronavirus that has never been seen in humans. It has previously been seen in bats, and that is what I'm told where the coronavirus actually started. Somebody ate a bat in another country, and the bat had coronavirus and it transferred to the person, which is a new thing that has just come about. All right, exposures or symptoms of COVID, generally 2 to 14 days after exposure to the virus. If you are exposed to the virus, you need to obviously self-isolate for 14 days because if you have gotten the coronavirus, you can still shed it even though you're not passing symptoms. I know when it first came out, they were saying that, nope, you have to have symptoms to pass it, but that is not the case anymore. You do not have to be showing any symptoms to pass coronavirus. Symptoms that are seen with COVID: cough, shortness of breath, or difficulty breathing. Sometimes that comes a little bit later. Fever, chills, muscle pain, sore throat. They're seeing where a person has a new sense of loss of taste or smell. We're also hearing, and I don't honestly know a whole lot about this, so don't quote me, but I do want to send it out to you guys who are parents, that there is another strain of the coronavirus that is infecting children that starts with a rash and high fevers. I know my mom told me about it, and she said one day on the news, it said one day she heard that they brought 17 kids into a New York ER, and 2 of them passed away. So just make sure that you're watching your kiddos. All right, treatment. There's no specific meds for COVID-19. So we just need to be preventative. Wear masks if you're going to go out. You do not have to wear gloves if you're going to the supermarket. Please do not wear gloves if you're going to the supermarket. Please. If you have symptoms, isolate. You can stop isolation once you don't have a fever for 3 straight days. If you know you are in contact with a COVID-19 positive person, you have to quarantine yourself for 14 days to make sure that no symptoms. If you do not develop any symptoms within those 14 days, you are clear. All right, moving on to croup. Croup. Where am I? I'm looking at my notes here. Holy cow, we only have a couple pages left. All right, croup. For those of you guys are parents, I'm sure that you guys have seen this once. Hopefully not, but it's an infection in the upper airway. These kids have a very barky cough. Generally, it's only in the peds, and generally it's treated at home unless there's other issues coming into play, other illnesses. But generally, croup is treated at home. I'm gonna check the next slide. Da-da-da. All right. Um, hold on. Okay, I found another oops in the slides. This slide um is supposed to be titled cystic fibrosis. I don't know why all the oh, because they were white. Sorry, you guys just saw my light bulb moment. Um, yeah, our titles were white. That's why they're gone. The title in this slide should be cystic fibrosis. It's a genetic defect in the protein, and it disrupts the functioning of like the exocrine glands, um, causing ducts and tubes to become clogged. So these people are going to have like the vests on them that are shaking them and getting that crud out for them. Can actually affect the airway, the small intestine, the pancreas, the sweat glands. Um, Used to be where people did not live past puberty with cystic fibrosis, but now they're living. General age expectancy is 37.5. Um, just because, um, yeah, they've been finding new treatments, new ways to help these people. It's a genetic cause. It's caused by genetic. Both parents must be carriers. Um, the movie that I think of is 5 Feet Apart. Um, she is in the hospital and she is in the cystic fibrosis wing, and she falls in love with another CF patient. But because if both people have cystic fibrosis, they can pass different organisms to each other and get somebody sick. They actually have to be at least, well, it's supposed to be 6 feet, but they push it a little bit and stay 5 feet apart. But they don't want to date because they both have cystic fibrosis, which means their child would have cystic fibrosis if they ever decided to have a kid. Cystic fibrosis, there's a lot of mucus production, and this mucus is thick and it's sticky and it's cruddy and it's yuck. But it plugs everything. But eventually these people will have cystic fibrosis or have COPD. Can do the sweat chloride test, a chest X-ray. Um, yeah. Um, they used to test everybody for it. But one way people would um try and determine if their baby had cystic fibrosis, they used to actually have a thing called Kiss Your Baby campaign. Um, so like you're supposed to kiss your baby and see if they tasted salty. Because the sodium and the chloride didn't like pass through the sweat ducts and it kind of sat there. So if you kissed your baby and they tasted very salty, um, because those electrolytes are actually lost through the skin, people would take their babies in and say, "I kissed him and they taste salty." And yeah, it's weird stuff that happens in the past. I'm a huge medical history buff. Just want to make sure I'm not missing something. All right, signs and symptoms, like I said, thick, nasty sputum, frequent respiratory infections, coughing, purulent drainage, clubbing of the fingers. Late stages of CF, you're going to see them coughing up blood because they're damaging their blood vessels in there when they're coughing. These patients are going to have steatorrhea, which is like fat in their stools. Their stools are going to be fatty, they're going to float, and they're going to stink. Because they don't have the pancreatic enzymes. Um, they have abdominal pain, and they can't deliver these digestive enzymes to their bowel. So they basically have a malabsorption syndrome. So they can't absorb what they need to, and it just kind of sits and they excrete it in their stool. Um, for these guys, we want to make sure that they're not trying to keep them from getting infections. We're going to treat them symptomatically. We want them to have a very high calorie, high nutrient diet. Um, yeah, sorry, I'm trying to make sure I'm hitting everything because I've got different notes. Um, and we want to get their genetic counseling done. There is no cure for it. They can sometimes there are lung transplants eventually, but the big thing is controlling and preventing infections. Um, Getting rid of the thick sputum. They use like these vibration vests, and it shakes them. The chest physiotherapy, um, chest wall oscillation, just with a thing they're beating on them, I say. It just helps them get rid of the crap. It's moving it and getting it out. Hot showers, nebulizer, and that high calorie, high nutrient diet. Um, because they have no appetite, so we want to get as much in them as we can. So anything that has high in calories, high in nutrients. What do we need? What do we need? A big thing with our CF people, we need to really make sure that we are not getting them around anybody that's sick, because they will catch it. This is in this file. I don't have it. Oh, yeah, I do. Alright, pneumothorax. You guys have all heard of this. It's just a collapsed lung. Whether it's, yeah, however it happens. P-thorax is the way to remember the symptoms. They're going to see pleural pain. That trachea might be moved to the left or the right a little bit. The hyperresonance, it's going to be very deep, very full sound. Onset is sudden, whether it's a car accident or an infection. You're going to hear very reduced or absent breath sounds on that side, and they're going to have they're going to have a tough time breathing. Absent fremitus, which is the vibration, which I don't expect you guys to know. And then an x-ray will show that that lung is collapsed. Biggest symptom you're going to see is shortness of breath. That's generally the first symptom they complain of. Oh, I'm really short of breath and my chest hurts. Pleural effusion. This is kind of like a collapsed lung, but it just means that there's fluid in that space and causing the lung to shrink. This person will complain of shortness of breath. There will be lots of fluid in there. Generally, people with fluid like this, they're going to get a chest tube. But they need, for positioning, we want them to lay with their good lung down. Because when the good lung is dependent, gravity causes greater blood flow to the lungs, and that increases the oxygen saturation. So we want them good lung down. And we made it through our PowerPoint. That is a very long one. Thank you guys for bearing with me. If there's anything you guys need, I am going to set up the Zoom meetings next week once I get your guys' surveys back. So just let me know, and you can email me too. I just suck at trying to explain things over email. I'd rather explain it face to face. So if you need anything, get a hold of me. All right, you guys have a wonderful day, and thanks for staying with me with the respiratory.